Hi, everyone, and welcome to today's webinar, Someone to Respond to Behavioral Health Emergency Mobile Crisis Teams. We're excited you are joining us today, and thank you for spending part of your day with us. I'm Chelsea Thompson, a Justice Program Manager here at the National Association of Counties. This webinar is part of a series of NACo webinars and briefs focusing on the behavioral health care continuum. Through national initiatives such as Stepping Up, MacArthur's Safety and Justice Challenge, Data-Driven Justice, and other justice reform efforts, counties are implementing programs that prioritize a health-centered approach to support community members with behavioral health conditions rather than relying on jails or emergency rooms. By developing these programs and practices that support residents before, during, and after a behavioral health emergency, counties may achieve their priorities as part of these initiatives. One-way jurisdictions are supporting community members during a behavioral health emergency is providing someone to respond through mobile crisis teams, or MCTs. Sometimes called co-responder teams, crisis response teams, or units, MCTs are community-based, face-to-face interventions that help a resident wherever they are physically located. They provide stabilization, treatment, and connection to services, as well as deflect individuals away from the criminal legal system. Counties across the country have launched MCTs along a spectrum of models. They range from civilian teams that include only licensed health care clinicians, peer support workers, and/or social workers, to units that pair crisis intervention team trained law enforcement officers with health professionals to respond to certain calls for services. Some models, such as Cahoots in Oregon, are well documented and serve as national model for jurisdictions. There are many innovative models that have been highlighted by organizations such as the CSG Justice Center, the Vera Institute of Justice, and Mark 43, which we'll share in the chat. Recently, the White House Office of National Drug Control Policy announced the release of the Model Law Enforcement and Other First Responders Deflection Act, a resource for states that encourages the development and use of deflection programs across the country. To get a sense of how folks on this call may be thinking about or implementing mobile crisis teams, a poll will appear on the screen asking the question, does your county have a team that responds to people experiencing a behavioral health emergency? Our responses for this poll are, yes, we have a team with a law enforcement officer and health professional. Yes, we have a team with only health professionals and/or civilians such as peers. No, but we're working on it. Or no, we are not currently implementing a team. I'll give everyone about 10 seconds to answer the poll. In a few more seconds. And great, and if we can close the poll, we can see our results here. Great, so it looks like we got a diverse group of people on the line. More than half of folks are currently implementing a team either with law enforcement, health professional, or just civilians only. So thanks so much for sharing this insight with us. Today, we have representatives from 3 jurisdictions that have implemented different versions of MCTs. First, I'd like to introduce Director Alexandra Martinez. She is the Director for the Crisis Center in Alachua County, Florida. Director Martinez, thank you for joining us today. Sheriff Robert Udell of Yakima County, Washington, will highlight the work the county is undertaking in this space. Sheriff Udell, we're excited to learn more about your work. And last, but certainly not least, Curtis Young, an operations administrator of acute psychiatric services from Parkland Health in Dallas, Texas, also joins us. Curtis, we welcome you to this conversation. Before I turn it over to our speakers, some housekeeping announcements. This session is being recorded, and the recording, as well as the materials shared here today, will be available on the NACo event page within the next few days. Please feel free to send questions for our speakers using the Q&A chat box, which is located at the bottom or side of your screen, depending on the layout. We'll save some time at the end of this conversation to have a discussion with some of our panelists. And now I'll turn it over to Director Martinez to provide an overview of the mobile response teams and care teams in Alachua County, Florida.
Good afternoon. Thank you so much for having me. I'm honored to be able to speak about our programs in Alachua County. I go by Allie, so Allie Martinez, Director of the Alachua County Crisis Center. And I want to talk a bit about kind of our history and sort of the context in which we operate in Alachua County, because we're pretty unique. And have been one of the few county-funded crisis intervention centers in the country. We're very proud of that, and it really has allowed us really strong relationships in our community with our partners, and has allowed us to kind of really build on what we have. So the Alachua County Crisis Center actually began in 1969 as a National Institute of Mental Health grant from the university to study suicide. And it began as a crisis hotline for the community, and actually became really appreciated in the community, really well utilized. And with that, the programs really grew. And in 1974, Alachua County decided they wanted to keep that hotline available to the community, and say that it took it as to become a county agency. And so since 1974, being a part of Alachua County afforded us the opportunity to really build upon that suicide prevention hotline into a variety of programs. Over the years, we were able to not just become that local crisis line, but from there, we were able to then begin our mobile response program and really build a close relationship with law enforcement, with the university, with the public schools, and build over the years. And I'll talk quite a bit more about that. We also began a counseling services program, so anybody could come see us for not only crisis intervention support, but face-to-face ongoing therapy services as well. And so at that point, we had the hotline, we had mobile response, and we had ongoing therapy services available to our community, really providing us the ability to have a broad continuum of care that we could offer in-house. Over the years, our education and outreach programs have become quite extensive. We are the local crisis intervention team steering committee lead. And so we coordinate all the CIT trainings for local law enforcement and for 911. We provide anywhere from 3 to 5 trainings a year for CIT. And again, going back to that relationship building, that's really allowed us to really build upon and strengthen our relationship with local law enforcement. We also provide extensive education and outreach programs throughout the community and even state and nationally, and work very closely with our public schools. So shortly after our mobile response team programs began, in addition to assisting law enforcement, we began assisting local schools for their crisis response needs, and have really been able to build upon that. I want to speak a bit about sort of how we're able to operate and how we're able to provide such extensive services. We have traditionally been a very small staff and primarily volunteer-based. Being in Gainesville, Florida, where the University of Florida is, we have been able to really have a wealth of volunteers available to us, people interested in learning crisis intervention and wanting to give back to their community. And so over the years, we've maintained a very small staff, but approximately 100 to 120 volunteers. Those volunteers are the ones providing the direct service on our hotline, and those are the ones primarily staffing our mobile response programs. So we have volunteers who have been with us for many years, who in a sense graduate to become mobile responders. And providing that sort of civilian response to crisis situations in our community has been incredibly valuable and really important. And what that's turned into is our relationship with both law enforcement and schools. There's quite a bit of trust in terms of them being able to reach out to us and ask for our assistance or consultation and our on-scene response to those who may have suffered any sort of mental health concern, mental health struggle, any kind of tragedy, an accident, a death, anybody on a scene that may need some crisis intervention, mental health support, potentially an assessment of some kind. So we are contacted regularly from law enforcement and by the schools to provide that response. Because of the depth of our relationships and the depth of our mobile response programs over the years, when an opportunity came forward from the state of Florida to directly provide services to youth 25 and under, every county in Florida now has a youth-focused mobile response program. When that opportunity came forward, we were naturally very interested and now provide what's called mobile mobile team response for youth. And that's just built upon our already extensive mobile response program in our community. And so now we're in the schools every single day, providing assistance to school resource officers, to school counselors, for youth who are struggling with a mental health concern or maybe at risk for suicide. So all of these programs together have really meant that in our community, it was a go-to for crisis response where law enforcement is not needed or where there is the benefit of having a civilian response. Locally, over the last few years, our local law enforcement, our sheriff's office, as well as our city police now have co-responder teams where they have a counselor responding with law enforcement. And so we are able to collaborate very closely with them when there are situations in which our teams may benefit or need law enforcement. We may call out the co-responder team to assist us. And oftentimes the co-responder team will contact us where they feel like the co-responder team, law enforcement, is not needed for that particular response. And so we work extremely, extremely well together, very closely, and just feel very, very lucky in our community that we have such a variety of crisis response options, mobile response options. And I've really kind of seen, working closely with NAMI, working closely with other sort of mental health organizations here locally, our community knowing that they have multiple options, multiple ways in which to have on-scene support for themselves, for a loved one, has been really incredible for Alachua County. We continue to be a crisis hotline, and we are part of the National Suicide Prevention Lifeline Network. And for 1-800-273-TALK, many of you may know that 988 will become the suicide hotline number beginning in July. And so as that transition is happening, there's also a critical discussion about how the suicide hotline, how 988 will be collaborating with law enforcement, with 911, to make sure that people who contact the hotline, who reach out to 988, are responded to appropriately and are aware of kind of what the different options are in their community, really trying to build a broad continuum of care so that people who are struggling, who are in crisis, who may be at risk for suicide, get the appropriate response, appropriate level of response. And so we're very proud to be very tied in with many aspects of that continuum of care, from the hotline to mobile response, to also the ongoing therapy services that we can offer in our community. And I think are a really good model for what things can look like. I'll say that we're aware that not every community has the ability to have such an extensive volunteer program as we do. We're very, very fortunate in that regard. But knowing kind of that we are fully expecting that with 988 and more awareness about mobile response programs, that our demand is really going to go up in the coming years. And so we are preparing by actually turning into a hybrid model where we will have both volunteers and staff working on our hotline and providing on-scene support, mobile response. So we're really excited by that because it's really going to allow us to kind of meet that higher demand and really sort of build upon our system. We're always going to have volunteers. That's very important to the heart of our program. Having people who are there because they want to be there, they have the heart for this work and ability to do this work. We always want to have that available to our community because that has a really special impact. But we're now building upon our staff to make sure that anytime there is a response needed, that we always have that availability. So really excited about that. And I want to go back real briefly and just talk about those partnerships. And it's one thing that I really have been talking a lot with other programs about, is kind of how important that is. Our crisis intervention team training program, we also assist with hostage negotiation training. We assist with the schools with suicide risk assessment. We take any opportunity we can in our community to provide education and consultation to organizations, to law enforcement, to schools. And that has been a key piece for us in terms of relationship building. We build partnerships, we offer education, we also go to trainings. I really encourage all of my team to do ride-alongs with law enforcement, with fire rescue. All of those are really critical opportunities for relationship building and partnership. And so that has been sort of a key part of our mobile response team program and why we've been so successful. Our MRT program for youth in particular, in these past years, we average about a 90% diversion rate. So we're able to divert 90% of the youth that we come into contact with away from hospitalization. We're really proud of that. We think as much as possible when it's safe, we want to keep kids out of the hospital, keep kids in their own environments, and work with the families, guardians, people in their life that can provide that safety and can provide that support that they need. So that's a key part of our philosophy with mobile response, working on those partnerships and making sure that we work collaboratively with the people that we come into contact with and their families or others in their life that can provide that support. So I will end there, but I appreciate so much. Thank you so much for the time.
And thank you, Director Martinez, for that great overview of all the work that you are doing in Alachua County and thinking about how to embed mobile response teams and helping folks on the ground. And so now I will turn it over to Sheriff Udell from Yakima County.
There we go. I'll unmute myself. That's helpful. All right. Thanks, Chelsea. Okay, so I'm going to present from the perspective of law enforcement and where we were, what we're doing now, and where we kind of hope to go. So next slide, please. So Yakima County Sheriff's Office, we have a county that's 4,300 square miles. It's the second largest county in Washington State. It's huge. And for mental health crisis, traditionally, a deputy would go alone unless there was weapons or certain situations, perhaps suicidals. The deputy would go alone and then literally be on his own. Now, deputies are pretty good at dealing with issues. We're very good at keeping people safe, but there's limits to what we can do. And so, and here was somebody that obviously needs more than we can provide. The deputies would be stuck. Now, they might call an ambulance or a fire truck would come out, but ultimately, what to do with them? The deputy can make the decision to contact or ask for an MHP, mental health professional, but then it would be up to us almost always to get the person in crisis to where the MHP might be. Now, again, that goes back to that 4,300 square miles and how to get somebody to where they need to be. Now, the MHPs often would be unavailable. And I myself have shared many a hamburger at McDonald's with somebody waiting for someone to give us some help. And it would get so, I mean, with the deputies would actually, and I've been there, you'd get that call and you'd begin to dread it because you knew, what am I going to do once I got this person? How was I going to help them? There was so limited, so many, so few options. And sometimes with no MHP, no services, no bed, what in the heck is the deputy going to do? Which leads to, next click, the worst case scenario. The subject is booked into jail, and that is no good from anybody's perspective, especially if you've seen our jail. It is absolutely the wrong place for people to be that are in mental health crisis to be in, but there was often no other solution. Deputies were waiting. There's other calls the deputies had to get out to. It was just bad news. I guess the solution was safe, but there was nothing else to it. All right, so next slide. But then 4 or 5 years ago, a couple of gals from the local mental health organization came and presented an option. The True Blood grant in Washington State is a result of a suit against the state for failing to provide diversion services for people in mental health crisis. As a result of that suit, there was a settlement with the state legislation, and there was a lot of money that was out there for DCRs, or different types of mental health teams. Comprehensive Health here in Yakima proposed DCRs in our patrol cars. The DCR would be with the deputies driving 2 calls, and obviously take advantage of our obvious first contact with those in mental health crisis. I mean, law enforcement is first line. We see it every day. The DCRs, they said, would be on-scene assessment. Then they promised much quicker mental health assistance for the deputy. And they thought that, well, we should probably have funding for 3 years and this will work. Now I thought, not bad. This sounds promising. I've been in law enforcement for 32 years now. I've seen a lot of programs come and go. I'm never one to not try something. I thought this doesn't look too bad. So the next slide. Here we go. When we left that initial meeting, I had my chief criminal deputy with me, and he said, it'll never work. It's not going to work. You're not going to be able to have MHPs, DCRs in the cars. The deputies won't like it. And the deputies do consider, all law enforcement considers their car as their office. That is where they spend almost all their time, and many are very, very protective of that space. And then you get down to the lack of trust. Is it going to work? Again, I mentioned all these different programs that come and go, but will it actually fly? And then DCRs. For a deputy, who are these people? We don't know who they are. We're gonna let them in the car. We have to work with them in the field. It just doesn't seem like it's going to work. And they have the expectation that this is going to be the same old response with minimal results. But next, what did happen? The results were pretty surprising. Immediately, they proved their worth. The first, I still remember the name of our first DCR. Her name was Friday. And Friday ended up in a car, and the guys loved her immediately. And it was amazing to them what that relationship provided. Their expertise brought about resolutions that were so much faster than before. I took her one time out to a call, and it was a young teen, and she would not talk to anybody except the DCR. Right there, you could tell there was the success. And a big part of the DCRs is they allow the deputies often to move on to different calls. DCRs can hang out with the person in crisis. They can start getting other services for them. The deputies move on. And I go back, and I'll keep mentioning this, that big county part for us, and the deputies have got things they need to do. Why not have a DCR there it's their specialty? This is what they get to do. This is what they're trained to do. And so the help was immediate. And it didn't take very long for us to realize too, the DCR is not just someone maybe that was, in crisis or suicidal, but our DCRs have intervened in elderly with housing, with people that can't pay their bills, people in all sorts of family problems. It's kind of crazy how many things they're able to deal with. And so now the deputies will come in and they will look for a DCR to ride with them, because it makes their job that much easier. And with the DCRs, we don't have to worry about taking someone to jail unless it's absolutely necessary. They offer that diversion, the great alternative to confinement that everyone on this Zoom today understands is not the best thing for people in crisis. Okay, next, please. So where do we need to go as far as the DCRs? Right now, we've realized that sometimes, back to that great big county, the DCRs need to be in their own vehicles. So I have provided vehicles for them at times if we feel a call is safe for them to drive to a call or to meet the deputy there. So that's it. It increases efficiency quite a bit. We're looking at in developing a training program to further support the DCR in the vehicle. Deputies often are in very remote locations, and there's been times when the DCR is the only friend to the deputy. And it may not even be a mental health call. It could be anything, but the DCR is in the car. And so we recognizing that, we're working on exactly developing limitations to what they should do, what they shouldn't be doing, and how they can help the deputy in certain situations that could even be violent. The DCRs are all provided bulletproof vests to wear to all calls. So they've got DCR emblazoned on their chest, mental health provider on their back. So they hopefully that people recognize who they are. But even with the vest, they continue to be a very, very positive a part of our response. And something else that was really big for us. You know, I've been doing, like I said, 32 years. Back in the old days, if you're a cop, you're expected to just man up and deal with issues. Didn't matter what you saw, what you had to deal with. You're expected to come to shift the next day without it affecting it. Is that what happened? Not really. Police officers experience above community averages of alcohol misuse, their health, their marriages, right? Divorces and suicide rates, way higher than the general population. We're working industry-wide on officer wellness, and the DCRs in the car are absolutely wonderful for that. About a year into it, we talked to one of our DCRs, and I asked him, I said, are you talking to the deputies about their concerns and issues? And he said, absolutely. Every day, he said, I'm with a different deputy, and we're talking about their own mental health. And I thought, wow, I mean, what a great benefit to that program is as well. Now, this June, the True Blood grant apparently is finally over. After 4 years, the money's drying up. The county passed last year an additional sales tax, so 1/10, 1%, and provides significant funding to continue the DCR program. We did a study, involved a lot of people involved in mental health services across the county, and the DCRs floated to the top of the list, #1 priority for the money to keep going. That important. Matter of fact, I couldn't even imagine going backwards, not having the DCRs in the car. That would be just not a good thing to do. So we've been successful in pushing that. So the tax is going to do that. Plus, we're going to we have at least 2 on at all times. Right now, there'll be shifts when we don't have DCRs, and I've listened to the radio when the guys call in and say, hey, is there DC? Big of a deal. So we're going to expand the program, and hopefully it continues on. There's also been some talk of forming teams with a medic and a DCR that would operate separate from law enforcement. But in our county, again, due to the size, we believe that it could be a little too risky for those teams to operate too far away from the cities. And so we're going to keep those teams likely confined to the cities where law enforcement backup is within minutes, unlike perhaps 20 to 30 minutes in the outer edges of our empire. So that's our program. And next, I guess this is my final comment on this. This is the best mental health program involving law enforcement in my entire career. I'm a huge supporter of it. I've been on the stage a few times in our own state talking about this program, and I think it's great. And those gals that came up with the idea, man, good on them, because we sure do support it and enjoy it. And Chelsea, that's all I've got to say about that.
Awesome. Thanks so much. Definitely could probably talk for the next few hours about this great program. And I loved hearing all about the evolution of the DCRs and really how it just changed everything and how you all are working in Yakima County. So thanks so much, Sheriff Udell, for that overview. And next, I will turn it to Curtis to talk about the R.I.G.H.T program in Dallas, Texas.
Thank you, Chelsea, and thanks everybody for joining today. First, I just want to say commend both my co-presenters here on the good work that they're doing. Impressed with both of their projects. So my name is Curtis Young. I'm Operations Administrator for Behavioral Health Services at Parkland Health. That is the county hospital in Dallas County in Texas. And I'm going to tell you a little bit about the R.I.G.H.T program. The R.I.G.H.T is, next slide, please. Thanks. So the R.I.G.H.T program it stands for Rapid Integrated Group Healthcare Team. And this is a mental health co-response model. The purpose of the team is to respond to members of the community experiencing mental health crises and to divert them from jail or hospitalization and provide them with connectivity as well as prevention and intervention services. So that's a lot of words. What basically this is a pilot program that started in 2018, January 2018, with the help of a grant from the W.W. Caruth Foundation. It was part of a larger grant program called the Smart Justice Program here in Dallas County. And this was a partnership of many different agencies coming together to address mental health and the criminal justice system, and how we criminalize the mental health system, and how we can start moving our community away from that. And so R.I.G.H.T was one of the funded projects of that larger Smart Justice grant, and one of the more successful and glamorous projects, actually. So the grant was awarded to an organization called Meadows Mental Health and Policy Institute. And they then sub-awarded the grant to two different entities, the City of Dallas and Parkland Health. And so how they did that is the City of Dallas basically provided the fire department and the police department, and Parkland Health provided a psychiatric social worker. And together they formed the R.I.G.H.T team. So we're going to talk a little bit about what that team looks like, how they operate, hours of operation, and all of that. So next slide, please. So initially during the pilot program, there were three main partners. There was Dallas Fire Rescue, Dallas Police Department, and Parkland Health. And since that pilot program ended in 2020, the city has agreed to expand that program with Parkland. And we've added another key partner, the North Texas Behavioral Health Authority. And so the role of the North Texas Behavioral Health Authority is that they have care coordinators that are actually embedded in the 911 call center. And they're helping those call takers that are receiving 911 calls that are identified as mental health 911 calls. So our call center, the call takers are very busy, but yet they're not always trained on how to handle those calls. So the clinician in the call center can really be an asset not only to the caller, but to the person who's taking that call, and to help kind of feel out what's actually going on and what might be the best team to respond to that call, whether it's only law enforcement, or maybe the R.I.G.H.T team, or maybe the mobile crisis outreach team. So their primary role is in the call center, the 911 call center. Dallas Fire Rescue provides us with a paramedic. Dallas Police Department provides a patrol officer, and Parkland Health provides a social worker. Those three entities are in a one vehicle response. So they start their shift at a police station, and they all pile into a Chevy Tahoe that has a Dallas Police Department CAD computer in it, and they go online, and they are actually their own unit, and so they can respond and be dispatched by 911 dispatch center to a call that's identified as a mental health 911 call. And so we're not waiting for the police to show up, and then the social worker comes later, and then the paramedic comes from the left. It's all a one vehicle response, so that we can do this as efficiently as possible. Previously, before R.I.G.H.T, how this worked is that any mental health 911 call would be there'd be 5 units dispatched, all police units dispatched, whether that patient was actively suicidal or they were just needing a medication refill for their psychiatric medications. So it was a very labor intensive, resource intense response. So obviously there was motivation to provide a better, more cost-effective way to respond to these calls, but also keep the safety. With R.I.G.H.T, we were able to come in and basically do things a little bit differently and get patrol officers back on the street. And I know Sheriff Udall kind of alluded to that as well, that it cut down on the amount of time that officers were having to spend on these calls. Before the pilot project, the research showed that Dallas patrol officers were spending an average of 70 minutes per mental health 911 call. 5 units, each for 70 minutes. That's a lot of time. So with this program, we now only dispatch 2 units unless we believe that there's a need for more. There's 1 patrol officer, and then there's the R.I.G.H.T team. So what's the role of each individual group? Well, the patrol officer, they take a different role than they would normally. Their primary role is scene safety. So when we roll up on scene, the patrol officer is going to get out of the vehicle, and they're going to meet with the caller or whoever's on scene at that point. Just make sure that the scene is safe. Make sure that there's no weapons, there's not a knife out, that where we're going to meet and have the interview and talk to folks is a safe space. They'll come back and brief the paramedic and the social worker, and then they'll get out of the vehicle and they'll join in the conversation. The paramedic will do a medical evaluation to make sure that there's no acute medical need that's happening that could also be attributable to the crisis at hand. Once the paramedic is done, then the social worker will do a psychosocial assessment as well as a risk assessment. And that's to kind of determine how best that crisis can be resolved, what level of risk is this person at, and then kind of go from there. So does this patient need to go to a hospital, or can we resolve the crisis in the community? Can we get them in to see their doctor same day, get them their medications, and have them home in 3 hours? Avoiding unnecessary incarceration, avoiding taking patients to busy ERs, which, by the way, Parkland Health has the single largest ER in the country. We have over 350,000 visits every single year. So we have a very distinct motivation to keep people from coming to the ER if it is not an actual emergency. Next slide, please. So the program objectives. We want to provide a comprehensive on-site services to persons experiencing a behavioral health crisis. We believe that this is a better way to provide the service. We want to provide prevention and intervention services for persons who are chronic users of emergency systems for behavioral health care needs. So we really focus in on who are our high utilizers, who's calling 911 all the time, and why. Is there an unmet need there that we can engage with that person and have their needs met so that maybe they're not using that system over and over again, and get them connected to a different system that's more appropriate. Maybe getting them connected with a caseworker or an outpatient mental health provider. Ensuring continuity of care following stabilization on scene, so hospital transport or emergency detentions. So an emergency detention, by the way, is what Texas uses to take people in for a psychiatric evaluation if they consider the person to be an imminent risk to themselves or others. Only a patrol officer can file this document. This is apprehension, or it's basically like a warrantless kind of way to bring somebody to a hospital for an evaluation. But that's also another reason why we need the police officer on staff, is that if we need to do an emergency detention, they're there to complete that form. By law, they're the only people who can do that in Texas. And also to disengage emergency responders from mental health calls to be made available for high priority calls. As I was saying, this no longer Dallas PD no longer needs 5 units to respond to a mental health 911 call. With right care, we can take over that scene. We can get patrol officers back on the streets, responding to other calls much quicker. Next slide. So the workflow, what does this kind of look like when we put it all together? So somebody calls 911, and the 911 call center determines that this is a mental health emergency. Maybe it's somebody saying that they're suicidal. So the 911 communications care coordinator will speak with them, possibly complete an assessment, also work with the call center employee as well as the dispatcher to determine if right care is the best way to handle the situation. Let's say in this case that it is. So dispatch then sends out the right care team. They're dispatched to that call as long with one other officer in most cases. And then the right care field team arrives on scene, performs the standard protocol that I told you about. First, the police officer ensuring scene safety, then the paramedic, and then the social worker. So social worker, generally, if it's not a medical emergency, then the social worker is going to determine the next steps. And this can be a variety of things to basically resolve the crisis in the field where possible. So looking at transporting to a psychiatric facility or even connecting them to a mental health provider. We have partnerships and collaboration with a lot of our outpatient mental health providers in town, as well as crisis centers that we can take people to and would get priority. So one of them is Metro Care Services or Southern Area Behavioral Health, where we can actually take a patient and call them ahead of time while we're en route and say, hey, we've got a patient that, they're not meeting criteria for that emergency detention, but they really need to see a doctor and they're agreeable to that. So we're going to bring them to you guys, and they'll get to see a doctor that same day, and actually potentially receive medications if appropriate, just kind of depending on what that evaluation looks like. It's essentially a higher level of care, but without going all the way to an ER or an inpatient psychiatric facility. And then we also provide follow-up. Somebody comes out of the hospital, or we meet with somebody. Let's say we meet with this person and we take them to the clinic, and then we bring them home after that clinic appointment. We're probably going to stop by the next day or maybe 2 days later to make sure that they're doing okay. They should have a follow-up appointment as well. So making sure that they know when that is, making sure that they make that appointment. We're not going to do this for everybody, but we're going to do it for the folks that we think need that extra follow-up and that extra hand-holding to make sure they don't fall through the cracks. So there are some folks also that might appear rather, that we might be concerned about, but that don't meet criteria to go to the hospital and they're not willing to go to the hospital. So then we're kind of stuck, right? So that might be somebody that we would follow up on as well. We might even see them later that same day or early the next morning to see how they're doing and seeing if they've improved or if we need to take them into an evaluation at that point. Next slide. I don't want to go over here, so I'll speed through these. We currently operate 7 teams citywide. We operate 7 days a week, 16 hours a day with 2 shifts noted there. And the way that you get right care team out to your call is that you call 911 and you ask for the right care team. Next slide. So just a little data to show you about our program since we've been around since 2018. We currently, with those 7 teams operating throughout the entire city now, we respond to 52% of all mental health 911 calls. And when we look at only the time period that the right care team operates from 7 a.m. to 11 p.m., we're upwards of 65%, I think, of the mental health calls that come in at that time. We are continuing our expansion to 10 teams throughout this next year. We plan to also offer services overnight. So we'll have 2 teams that will launch overnight. Parkland Health, where I'm from, we've seen a drop in our emergency detentions by 20% year over year since Right Care expanded to 7 teams. So it's very significant. It's hundreds of patients fewer that we are seeing in our ER as a result. So we are seeing a very direct impact of the expansion. Other program data and outcomes, we arrest approximately less than 4% of all the people that we see actually end up in an arrest. And that's largely going to be because of a family violence situation or pre-existing a warrant that was out for their arrest or something like that. We divert 20 to 30% from jails and ERs, about 17 to 20% to mental health care. We follow up with about a quarter of our folks and take about 20% to the hospital. And that's all I've got. Thank you. Appreciate the opportunity.
Great. Thank you, Curtis, so much for giving that overview of the Right Care team in Dallas. It's great to just hear about the workflow and how that team really works in Dallas, as well as some of the data and the outcomes so far. So now we have some time for some question and answer for our panelists. And so for folks who are joining us, if you have any questions, feel free to put them in the chat or the Q&A box. I know I've seen some come in that Sheriff Udell has already answered, so thank you so much. I will ask the first question since I can unmute myself. So for our speakers, what do you think are the key ingredients to successfully implementing a mobile crisis response team?
This is Allie. Honestly, I think that the key ingredients would be strong partnerships and strong training and a very clear sense of guiding principles and philosophy around how you respond. I think that's been really, really important to us. Our crisis intervention training has really evolved over the years, but at its heart has always maintained the sense of how important it is to collaborate with the people that we're helping, to really make sure that we're giving them voice. And, those basic principles of empathy and active listening. And they sound simple, but that has guided us in the development of every single other program that we've developed and is a key part of our mobile response. And when we're training our partners and collaborating with them, we're sharing with them very upfront sort of who we are and what's important to us in terms of our values and working with the public. And being very upfront about that and training others and our partners in those principles has been really, really important. So anybody who contacts us knows exactly what to expect. They know how we operate. And I think that's only built a lot of trust and really strengthened our relationships.
I think Allie's answer is spot on. She kind of, that's what I would have said almost exactly, maybe not as good though. So that's perfect. It really comes down to creating that partnership for us with the mental health professionals or the DCRs, and then having clear goals. What are the expectations of that partnership? And that's what's made it really sing.
Yeah, I agree with both of them. Partnerships are extremely important. We don't, I always tell my folks, we don't operate in a vacuum. So we can't, even as a team, even if we're doing an assessment, we're determining an outcome. What really makes the thing work is that we have places to take folks, that we have other, other resources that we can resolve those crises with. So it's not even just the partnership within our team, it's the community partnerships even outside how that team operates.
Great, yeah, I think communication, collaboration, partnerships are key really to anything successful. And so could you all just talk about what that evolution of that partnership looked like and kind of how did it start? What were maybe some of the challenges and obstacles as you were building those relationships and partnerships? And how did you overcome some of those hurdles?
It's interesting for us. I kind of look back at our history as a crisis center in our community, and there have been very, very important key events in our community, including the student murders that happened in the early 90s, where we worked very closely with law enforcement, with all emergency services during that really scary time for Gainesville. And out of that actually was born our rumor control critical information line, our 311 line. And so I think it's, knowing that for us, kind of when there has been something that has kind of tremendously impacted our community, we have been sort of first to kind of jump in and say, hey, like we want to help. This is our expertise. We want to help provide the support, the education, the consultation. So I think that has been really important over the years. But the other thing is also being very respectful and willing to learn about our partners and their expertise. And so, for example, with our crisis intervention team training program, rather than just us as the mental health experts providing the training, we've built a system where we have co-trainers who are our law enforcement partners. So we have a mental health person and a law enforcement person who are guiding the training throughout the week. And that's been really successful. So I think knowing what we can offer, but also knowing what our scope is and asking for education and training from our partners. I think those have been the things over the years that have really helped us strengthen those relationships.
Exactly, she's spot on. When we started out, there was a lack of trust because you didn't know what was going to happen with these new people. But the first few DCRs that came in were absolutely great, and so it paved the way for the future partnerships. Now, occasionally we've had a DCR that's a little different personality, right? That's life. Not everybody's the same, and so we've learned to just make sure that they're with a deputy that gels with them, that works, and that's important. So everyone gets to know each other, and there might be a few month process, like where they bed in with everybody. But it ends up working. We have enough varied personalities, just like the DCRs, that we find people that will work well as a team. And I like Allie's comments about, understanding what can they do and then to train us. And that's happening now all the time, going back and forth with learning what they do, what we do. We're getting our DCRs into more law enforcement training. They absolutely enjoy that. It's something different that they've never seen. And on this flip side, our guys are getting more mental health and crisis intervention training through them. So as it just gets better and better and better, we're looking at using our DCRs as hostage negotiators. It's perfect. It's in their wheelhouse. There's just a lot of advantages to dealing with those or building those partnerships. And We just keep adjusting, so it gets better and better all the time.
I think for us, there's a number of things that kind of come to mind. This isn't all hunky-dory right from the beginning, right? There's a bit of an adjustment period of, for instance, police officers are very black and white in terms of this is right, this is wrong, and that's kind of the way law enforcement works, and there's nothing wrong with that. We need that in society. Social workers, however, we live in the gray world, and so when you put them all in a car for 8 hours and they ride around together, you start to kind of see where that differences come into play. And so they kind of got to work through some things sometimes, and we had to be very clear on our standard operating procedures on whose role is what and whose role it isn't, and things like that. So some very interesting things kind of came out of that. I was going to say something else, but I forgot, so we can move along.
Yeah, some great lessons learned, especially Director Martinez, to your point about learning goes both ways, and really capitalizing on that piece. So one question came in that says, speaking of partnerships for the co-response models, were labor unions at the table for the development of these programs? Was union agreement required to implement the programs beyond a pilot basis?
For R.I.G.H.T, we didn't have any unions.
Yeah, we have unions, but in this case, there was not an issue.
Great. And the next question, do the mobile teams work remotely or in the office?
For R.I.G.H.T, all the teams are working in the office as their Tahoe, so they're actually responding in real time. There's no remote work.
At Alachua County, it's a mix. So our staff have offices, but a lot of the work is being done remotely. Obviously, for our volunteers who are responding, they're able to kind of come into the office as kind of needed. But actually, as we're building out and due to everything with the pandemic, we're actually going to be shifting more and more to a hybrid for everybody. So a bit of remote and a bit of in-office.
The DCRs are generally in the cars, out in the field, but you'll find them often in the office. And they do a lot of follow-up work, as well as getting resources to people. And the deputies often give them now projects to help, with sticky cases, so to speak. So you'll see them very often doing that and doing reports. Otherwise, they are in the field where they do us the best good.
Thank you for that insight. Do any of your mobile crisis teams include peer support specialists?
This is Allie. Alachua County, we just finished writing a job description for one. We're going to be hiring a mobile response team peer specialist, and we're very excited to that addition to that program. We think it's going to really just only enhance our ability to respond and add a very important, critical, sort of different dynamic to our response.
We have several deputies that are trained as peer support, and I believe all the DCRs have the same training. So they work very well hand in hand. And when we have a significant event involving a deputy or a crisis in the field, the DCRs often work as peer support if a deputy is not available for that. And what's really cool is to see that the deputies have come to trust the DCRs to that level where it's very easy for them to talk to them. And I think I talked about that in my presentation. It was the unforeseen, what the deputies were going to get out of it as well.
Mm-hmm. Definitely sounds like a really good unintended consequence. For your outreach, are you doing strictly outreach in the community, or are you outreaching into the emergency departments as well?
For us, for R.I.G.H.T, we stay in the community because our emergency departments have their own process for how they're going to do an evaluation. or if they feel like a patient is at risk, they have their own internal process. So we're not going to kind of step into that. We're strictly 911 response, or we'll go to an outreach for like presentations, or if somebody calls us and wants us to come out, we'll do that.
That's the same for Alachua County. We often will respond to ERs, but that would be law enforcement driven. So if law enforcement feels like it would be helpful for us to be involved, but we're also very respectful and careful to not step on toes, and always check in with the ER social worker to talk about sort of what role we can play. We do respond to ERs more for accidents, tragedies, things like that. So less on the mental health side and more on the grief support crisis side. But usually when it's a strict mental health situation, the ER has their own process.
Yeah, that's the same with us. The emergency departments have DCRs assigned to them as well as part of this program. So they don't go in the field, that's their station. There will be times if one's not on, that a deputy will take one of our field DCRs, but generally they're in the field.
Fantastic. Appreciate all of your insight. I don't see any more questions. So the last question we'll wrap up with as we close the end of the hour is, what is one piece of advice you would like to pass along to jurisdictions currently implementing or interested in implementing mobile crisis teams?
I would just say again, kind of what I said earlier, that really be clear on sort of what is your philosophy, what are your principles, guiding principles around sort of how you are operating, what is your goal in terms of your relationships with the community, so that when you are building your partnerships, you can have that really sort of clear conversation, really direct conversation about the intent of your team. And also be honest about sort of what your scope is and where your expertise lie, and where are places that you really benefit from learning from those partners.
Exactly. A clear goal and expectations is critical to success. And for us, having done that, now selling the program is very, very easy. And like all jurisdictions, my Board of County Commissioners is pretty tight with a buck, and we have shown the value. I mean, they got it. And it's all a result of making sure the partnerships are solid and we knew where we wanted to go.
I would say, evaluate what the needs are for your city or your county. What works in Dallas isn't necessarily going to work in Omaha or in a more rural community. So, we have a lot of really pretty heavy drug use in our city with PCP and cocaine and methamphetamine, like that maybe other communities don't have. And so, you might just need to kind of tailor your program to what you need.
Definitely all really helpful pieces of advice and lessons learned to apply to other jurisdictions. Director Martinez, Sheriff Udell, and Curtis, thanks so much for joining us today. I really appreciated learning about the work that you are doing in your jurisdictions, and I hope you as attendees also really learned about some great resources out in the field for those who are interested in implementing a mobile crisis team, or if you already have one. I hope you can also join us at our next webinar, which is on Monday, April 4th, which will be focusing on crisis triage centers. As a friendly reminder, this webinar is being recorded, and we will share the recording as well as the slides and the materials shared during this webinar. I hope you have a great rest of your day. Thanks so much.
All right. Thanks, Chelsea.
Thank you all.